Yeah, hi everybody. So I think we're going to first introduce each other here, and I'm first Udo Hoffmann. My name is Udo Hoffmann. I'm a cardiovascular radiologist, many years at MGH, and I'm the Chief Scientific Officer for Clearly.
Hi again, my name is Ido Paz. I'm a cardiologist at White Plains Hospital in Westchester, New York, and I lead medical affairs at Hello Heart.
I'm Dr. Rekha Kumar. I'm an endocrinologist and obesity medicine specialist at Weill Cornell, and I'm the Chief Medical Officer of Found Health.
Good afternoon. I'm Laurie Witzel. I'm National Vice President of Policy Research for the American Heart Association, and I'm Senior Advisor to the National Physical Activity Alliance, where we're working on policy and systems change around physical activity promotion.
Hello, I'm Namita Lokre. I'm the Director of Corporate Strategy at Valencell, and in my role, I lead the digital health strategy for the next generation products.
Good afternoon, everyone. Dr. Aziz Istatius, Interim Chair for the Department of Informatics and Health Data Science, and lead the Media and Innovation Lab, and looking forward to chatting with you soon.
Hi, Eric Schrei. I am a cardiologist out in Washington State, and I also do innovation and research with the DoD informatics space. We'll be talking about language models with regard to the DoD space.
Thank you, everyone. I'm David Santasanio. I work as our strategic business lead with our Center for Health Technology and Innovation. So we are looking forward to sharing the stage with these credible people around what's new in the Innovators Network. And if we have some time for some question and answers after, we'll go and do that direction there. So before I hand it over, I just want to remind everybody that our vendors who are here displaying their booths, and they would love to have you come by to see what they're doing, try out their product services, and just something that they're part of what we're doing. When we say what's new in the Innovators Network, these are the people that are bringing their products and services for you to enjoy. So let's get started, and let's bring up our first presenter. Udo?
Thank you. Can you help me? How do I bring up the slide? All right. So I want to talk about something that is central to the mission Clearly, but it's also a very important health problem. So my talk's entitled Treating Risk Factors to Treating Disease. Can coronary CTA provide personalized prevention for myocardial infarction? You know, when we think about it, the real-world effectiveness of first-in-my prevention is pretty disappointing and low. So here are data from 5 million patients that experienced a first myocardial infarction from a large database, claims in EMR database. And what we can see here, mostly confirmatory, is that half of these patients have their first MI without prior symptoms. Furthermore, a significant portion is not seen by a PCP, and a similar portion is totally unaware, for example, that they have high LDL levels. And as a result of all of this, the majority of these patients is not treated with appropriate preventive medical therapy. So who is at risk and how to treat them? This is what you're all familiar with. This is the ACVD risk score, which is the risk stratification instrument that is implemented in the guidelines for primary prevention. And when we look at this, it's quite in effect, it's a population-based risk stratification instrument, but on an individual level, it's quite ineffective. Up to 30% of patients who suffer first MI have actually no traditional cardiovascular risk factors. When you look at a group at high risk already, the patients who have diabetes, prediabetes, or metabolic syndrome, the majority of them is actually lumped together in the highest risk category, more than 20%. And it's really hard for patients who have no symptoms and have not seen their disease to comprehend what a 10-year event risk of 2.3% or 23% means. So inaccurate personalized risk estimation is a problem. Now, how to treat them? Well, the era of statins only is long gone, and people have recognized cardiovascular or coronary disease as a multi-system disease, and so there's many treatments that have become available over the last 10 years, and this list is going to grow expeditiously over the next 10 years. And so treatment is not really the problem, but who to treat and how effective and affordable care is the problem. So where can we look for an example where a personalized care has been already implemented? And this is a Keytruda, a cancer drug for lung cancer. And when you look at the disclaimer here, a prescriptive for adults with non-small lung cell cancer that has spread, who are positive for PHLI1 and whose tumors do not have to have abnormal EGFR or ALK gene. So that is what I call a personalized medical therapy. So can we get to the same level that we have established in cancer for the prevention of MI? And so it's not only lung cancer, but across the field of cancer prevention, we have moved on from physical exams. I don't think anyone would wait until a patient comes with blood in their stool anymore, or comes to the doctor with cough and fever or other symptoms. In all these instances, we have guideline-based and very successful imaging of disease established, staging, imaging, detection of disease, and staging of disease to personalized cancer treatment. When you compare this with MI prevention, we still measure surrogates, for example, LDL levels, which are great to measure the modification of risk, which are very poor to establish an accurate baseline risk. We still wait for symptoms to occur, and even if symptoms occur, we still don't measure image the disease, but we do stress testing to detect sequelae of the disease. But we do have already the instruments to actually detect and stage the disease. So there are solutions, including the one from Clearly, that accurately can quantify plaque, stenosis, ischemia, all the important elements that have prognostic importance in these patients. And so this is an example for a group at high risk, diabetes, prediabetes, and metabolic syndrome. And these are data, preliminary data from the CONFIRM-2 cohort that show how you can stage these patients based on the presence and extent of coronary disease. These patients, while ACVD risk score appear as a big group that is approximately at the same risk, about 25% 10-year risk. But when you apply CAD staging, you can very well distinguish very different groups at risk, from 0.6% to 5% per year. And so that is remarkable. And then once you do that, you could actually think about tailoring preventive medical therapy to the various levels of risk that you have identified. For example, defining more aggressive LDL goals for higher stages of coronary disease and adding a number of medical treatments, again, based on increasing baseline risk. And we have these data, but we don't have the trials how this works in actuality. And that is why Clearly yesterday announced the Transform trial that we are sponsoring, which is a CAD screening trial in asymptomatic patients. And that is very briefly the design of the trial. So patients with prediabetes, diabetes, and metabolic syndrome who are asymptomatic will be randomized to a standard of care where the care is executed based on traditional risk factors and ACVD risk score, or to a group, what we call a personalized care strategy, where the care is tailored based on CAD staging, and the outcome or health outcomes in this trial. So I think this trial and our work brings together traditional and new concepts for MI prevention. Our goal is to create the scientific evidence for the medical and patient community to see whether, in fact, personalized care based on the detection and staging of coronary disease is more effective than the care based on traditional risk factors. And our goal is also to democratize the access for patients to personalized risk estimation. Thank you very much.
Thank you, Dr. Hoffman. Now, Dr. Paz, next, please.
Great talk, Dr. Hoffman. So while that's loading, my name is Ido Paz. I'm a cardiologist at White Plains Hospital, which is a regional hospital in Westchester, New York, and I lead medical affairs at Hello Heart. So for those who don't know, Hello Heart is a digital therapeutic which consists of a mobile app with a connected blood pressure monitor that is available to over 2 million patients as a no-cost health benefit. And the capabilities on the Hello Heart platform include a couple of key functionality. One is the ability to track blood pressure, cholesterol, activity, other heart health metrics, either directly through the blood pressure cuff or through integrations with Apple Health or Google Fit. There's also detection of irregularities, so clinical-based workflows. If a member has a hypertensive crisis level reading or an irregular heartbeat detected, we have clinical-based workflows to try to make that highly actionable, have them understand what to do about it. The core functionality is digital coaching, which is powered by AI, and I'll show you some of that on the following page. But essentially taking some of the kind of fundamental beliefs we have around diet, exercise, and other kind of basic lifestyle habits and delivering it to patients in a highly personalized and highly actionable manner. We think a lot about reporting, which is essentially members are collecting robust information on the platform, but we want to get it back to their provider, so ultimately the provider can leverage that information to improve the care that patients are getting. And then finally, we think a lot about health equity because digital health solutions have the potential to be very equitable, and we've shown that in prior research we did here last year, and actually a colleague of mine was just presenting another poster on social determinants of health. So in terms of kind of the digital coaching and how we leverage AI, how we make this interesting, I'll show you just a couple of screens on the app. So on the left here, I think is a great example of personalization using AI. So as I told you earlier, a member could connect their activity tracker, their weight, and of course they have their blood pressure. So in the background, our AI is running a calculation, and if it notes that you as a member have been walking more and your weight has gone down or your blood pressure has gone down, we're going to fire off a highly personalized insight. It's personalized to an N of 1 saying, great job, you've been walking more and your blood pressure went down. We're all about the positive messaging, creating kind of a reinforcement of good health behaviors. In the middle here is just a nice example of a basic diet diet, exercise, kind of lifestyle habits, where we take kind of guidelines, which I joke as a cardiologist, I might tell you to do 20 different things, take a med, get your blood tested, come back in 2 weeks, by the way, become a vegan and work out 2.5 hours a week, right? But we break that down into more kind of achievable tidbits, like this one here, which is talking about just adding one vegetable into a meal today. And then we also think a lot about kind of additional personalization and health equity. On the right here is a screen from a feature we launched last year around heart health and menopause, just increasing awareness around increasing cardiovascular disease risk among women in menopause. So we think a lot about clinical outcomes. I mean, it's great if you have a nice solution, but I think, where are the outcomes, right? So we've published a lot about this. This is a paper that we published in the JAMA network where we looked at almost 30,000 Hello Heart members over a 3-year period, and we showed really nice sustained reduction in blood pressure. So among those with uncontrolled blood pressure greater than 140, 84% of them reduced their blood pressure. They were able to sustain that reduction for a 3-year period, and the reduction was really quite notable. It was 21 points. Which, obviously you guys know this, but a 10-point reduction might buy you a 20% reduced risk of a heart attack or a stroke. And this is twice as good as other digital health solutions, which, come from a lot of things, but really it's about patient member-centric design and creating a really highly engaging platform. So what are the next steps for us? more research. That's a lot of what I do in my medical affairs role. We actually have a paper coming out which has been submitted for peer review where we look at even a larger population, over 100,000 members, and we see really pleiotropic improvements, blood pressure, cholesterol, and weight reduction. So stay tuned for that one. And also looking at medication adherence. Aside from just medical outcomes, our customers worry a lot about healthcare utilization. So, for example, we have analyses show that members on Hello Heart will see a savings of $2,300 within the first year. This is another type of that analysis, which is kind of adjacent to clinical, where you see increased medication adherence from our medication tracker. We're also always thinking about new functionality to build into our product. So one is around symptom tracking, which we think is going to be just a useful feature for our members, but also going to help with some of our more novel data science applications like risk prediction, and thinking a lot about care gaps. So white coat hypertension, mass hypertension, ensuring that all of the data that our members are collecting are there with the provider at the point of care. And then, of course, we're always looking to grow. We are now, as I mentioned earlier, Hello Heart is available to 2 million members. Usually it is a health benefit through their employer, available at no cost, but kind of growing to more employers, more health plans, Medicare Advantage. Really, there's lots of different avenues that we hope to distribute this, because obviously cardiovascular disease risk is a huge problem that we're not really treating well. So I want to thank Pat and the Innovators Network for really, it's been instrumental for us to kind of come and have a venue to present, meet other talented people, some of whom you'll be hearing about in a minute. And I thank you for your time.
Thank you, Dr. Paz. Now, Dr. Kumar, please.
Thank you. You'll see some themes with Dr. Hoffman and Dr. Paz, and also my interest in personalization, but more related to obesity care. Oh, I can look over here. Okay. So I'm the Chief Medical Officer of a digital health platform called Found Health that focuses on obesity treatment. And Found combines evidence-based behavior change plus medical management of obesity, and the care is delivered through technology. So all the components of Found, similar to Hello Heart and a few other platforms, are physicians and nurse practitioners. Ours are trained in obesity medicine. Many are certified by the American Board of Obesity Medicine. We also have several health coaches that deliver behavior change treatment, nutrition, exercise, sleep, stress, through health coaching, one-on-one, but also delivered through an app. And that is also where Found is leveraging artificial intelligence, is on the coaching side to help personalize behavior change treatment. Found Health also has an entire telehealth component where we can prescribe medication for obesity treatment if somebody meets criteria. In addition to our physicians, medication management, and behavior change, we also do have a very active community that helps people stay engaged. We have now treated over 250,000 people at Found Health and continued to follow many on their weight journey. Something that people feel is very helpful and supportive is the Found community, where they can share their wins, talk about their challenges that they've had, or back steps in their weight journey, and the community cheers them on, helps them keep going. Sometimes people talk about their medicines. It might be the first time someone's tried FDA-approved medicine for their weight, and they may need the support of others who are on the same journey. So do we just prescribe the same medicine for everyone? This is a really popular topic right now. How do you know what medicine to prescribe for obesity treatment? And we don't prescribe the same medicine for everyone, just the same way we may approach cholesterol, hypertension, cancer. We want a personalized treatment. What's so complex about obesity versus perhaps personalized cancer treatment is that we don't have genetic targets unless we're talking about some very rare childhood forms of obesity. So we really need to ask the right questions to find out the root cause of why our patients may have weight gain, abnormal weight gain, and excess body fat. So on this slide, we are representing the different root causes of obesity in order to personalize treatment. And we do this at scale at Found through our technology. For example, a profile of person could be somebody with uncontrolled cravings. Those people are different from people that feel the inability to feel full, which is a different underlying biology than those that have blood sugar problems, prediabetes, carbohydrate intolerance. Those people are all different from people that describe themselves as volume eaters, large appetites. They feel that they eat more than others. And then at the bottom right of this slide are people that may have a problem with overweight or obesity that's amenable to lifestyle change. And we do believe these people exist. Sometimes they're night shift workers. There are things in their environment that if you could change their environment and lifestyle enough that you can conquer their obesity, overweight, and metabolic disease. So those same profiles I showed you on the previous slide of pinpointing the root cause with a detailed medical history, lab work, a family history, because we lack genetics in this field, we use those profiles to match medical management to the root cause. For example, that patient profile I told you that you can tease out the uncontrolled cravings, that's perhaps people that could be prescribed the combination of bupropion and naltrexone. Those are two generic medicines. They've been around a long time. They're FDA approved under the brand named Contrave for obesity management. The group of people that describes lack of satiety, the combination of phentermine and topiramate, which is an FDA approved medicine called Qsymia. For people with prediabetes, carbohydrate intolerance, family history for diabetes, the GLP-1 class of medicines is a good option. For those that may have increased appetite, off-label metformin can be successful when paired with the right diet. And for those that do not need or do not meet criteria for anti-obesity pharmacotherapy, Found has a wellness path where we can prescribe behavior change, include all of the coaching, all of the help with sleep, stress, nutrition, exercise, as well as access to our community without the prescriptions. So why hasn't there been a solution that delivers consistent, sustained results? The reason for that is much of the old school legacy weight loss platforms were only based on behavior change. They were based on eat less, exercise more, and they didn't really work for everybody. What about local providers going to your PCP? Only 1% of physicians in the country are trained in obesity medicine, and the burden of disease in the United States between overweight and obesity encompasses 70% of the US population. So there's just limited expertise. How about academic weight management centers? We have Dr. Lou Aroney sitting here, who is the Weill Cornell professor of metabolic disease and has an amazing academic weight management center. That's probably where people do things right, but they haven't fundamentally been able to scale. What about the other telehealth point solutions? So we've seen other companies that have wanted to treat obesity through diet and meds. What we found was a limitation of these is that they take one approach. Maybe they're GLP-1s for all. What if someone doesn't have access? What if it's not the right medicine? What if they have a contraindication? Or it's one diet. Let's treat everyone with a keto diet. Obesity is a heterogeneous disease. We need a wide toolkit of meds and a wide toolkit of behavioral interventions where Found can provide all of that. So the realities of GLP-1s. Everyone's talking about this. Why not just give everyone GLP-1s? The truth is not everyone responds. This is a little bit of an outdated slide now. I said maybe a 50% response rate. It's higher than that now. But not everyone responds. And you don't want to prescribe a $17,000 a year drug if there's going to be an inadequate response. Also, these meds must be continued in order to sustain or maintain weight loss. So again, you really want to make sure this medication works if you need to be on it long term. And the cost is a concern. So if we just say GLP-1s for everybody and they don't work and they're expensive, that's not a very practical plan. So at Found, we include our clinicians can prescribe a wide toolkit of meds that include generic meds or step therapy prior to getting a GLP-1 if that's the most appropriate. In order to improve our business, we continue to have clinical case reviews, quality reviews every week on the coach side, on the physician side. We're able to look at lab work as well as very detailed histories. On the coaching side, we have psychologists, psychiatrists focused on all of the aspects of the psychosocial situation involved in weight. So really quickly, our efficacy data. How well do people do on Found, especially if not everyone is on the most potent GLP-1? So this is looking at generic, inexpensive meds, the typical weight loss seen, and what we see at Found. So many of these meds show very small, maybe less than 5% weight loss when they're prescribed on their own. When prescribed at Found, we can reach 10% or more, which is more than clinically significant. And this is our efficacy data, not including GLP-1s. So Found outperforms results from clinical studies by 13 to 230%. Average weight loss at 3 months is 5%, average weight loss at 1 year is 10%, and 25% of our members lose 15% of their body weight at 1 year, and this is on generic meds. We did not include GLP-1s in this analysis. So significant gap exists in the legacy weight care approaches. A digital health platform like Found can fill this gap. So I think I've exceeded my time. Almost. So the purpose of Found is really to provide holistic management across the spectrum of metabolic health, incorporate generic meds with brand name meds, as well as GLP-1s when appropriate, but it's not the first thing we do due to access and cost. We also are very much emphasizing the behavior change aspect, and that is probably the way that our members interact the most with the platform. And we do a phased clinical approach, nutrition plus exercise, then generic meds, then GLP-1s if indicated. So this is a modern approach to weight care. We're called Found because we believe that the weight journey is not about what you lose, but what you have found in your new improved metabolic disease and your increased functionality.
Thank you, Dr. Kumar. And Dr. Witzel, please.
There we go. Well, it's great to be with you this afternoon. I'm going to talk to you a little bit about some of the policy and systems change work we're doing around physical activity specifically. So just to say, we've been doing advocacy and policy change at the American Heart Association for 42 years now. And we started out really focusing on NIH research and tobacco, and now we've expanded across a very wide public policy agenda. In physical activity, we are working on a number of different areas. And one is just to basically promote physical activity assessment, prescription, and referral across healthcare delivery. And this is recommended by numerous physical activity guidelines in the United States and across the world, as well as other evidence-based policy documents. I would just say quickly that I was on a call right before this presentation. We're already starting to think about the next physical activity guidelines for Americans. Unlike the dietary guidelines, the physical activity guidelines are not in statute in Congress, but they're done every 10 years right now by the Department of Health and Human Services. We released the last ones in 2018 at our scientific sessions in Chicago, and we're already working with the Department of Health and Human Services thinking about 2028. And we're starting to think about some of the major issues that will have to be covered in the next guidelines. So we're excited to be doing that work. And so in the disease state, we're working certainly in cardiac rehabilitation, trying to increase uptake, utilization, virtual delivery of cardiac rehab, expand those who can prescribe it and those who can direct it. We're working on a national coverage determination for patients with preserved ejection fraction heart failure. Talking to CMS right now about a secondary analysis to see if we can get that coverage through. And we're working with national partners, of course, CDC, AACVPR, and others. This nice change package has been developed by Million Hearts and AACVPR. We're helping to promote that, really helping hospital systems and providers promote cardiac rehabilitation. The other thing I'm doing is helping to lead the Physical Activity Alliance. We have come together as a community to speak with one voice on policy and systems change with a mission to really help all Americans enjoy physically active lives. We have 17 board-level organizations. The American Heart Association is one, and we're providing administrative backbone to the Alliance. but we reach over 100 other organizations across the breadth of our work. We've got a number of major initiatives, but one of them is our It's Time to Move campaign. This is a multi-year, multi-pronged effort to integrate physical activity assessment, prescription, and referral into healthcare delivery. And so this past year, what we've been working on is building standardized measures, because what we heard from those who wanted to integrate physical activity into their health system is the first thing they had to do was get measures into their EHR. And so we thought if we could do that nationally, it would be a big help, we would help solve that initial issue that a lot of people were facing. So we worked in HL7 to build an implementation guide this last year for not only the assessment, but also the prescription and referral. We were successful in getting that implementation guide done. It is now out for the first version of standardized use for anybody who wants to integrate it into their clinical and patient workflow. So that's one of the things we worked on. We also then worked with the Office of the National Coordinator to get physical activity assessment incorporated into all EHRs, to get it incorporated into the U.S. core data for interoperability. So I'll talk about that in a minute. Here's the link to our HL7 implementation guide. If you're interested, please see me and I can get you connected to that. And if you want to integrate into your health system, that would be fantastic. But like I said, we worked with the Office of the National Coordinator to get physical activity assessment into the U.S. core data for interoperability. This would require physical activity assessment in all EHRs across the country. We were successful in getting into version 4. It was published in July of 2023. It's going to take a couple of years for this version to get integrated into federal regulation, but we were excited to achieve that in 2023. So that's, I think, going to help us on our journey toward making this a standard of care. We also know that our conversations with the White House, we were hoping that the IRS would clarify some guidance they had about using health savings accounts and flexible savings accounts for memberships to fitness centers, et cetera. They actually, in March, provided this additional guidance, and so those who have those kinds of accounts can now use those dollars to join a fitness center if they have a letter of medical necessity from their physician, from their clinician. And so we're getting a lot of questions about this right now from the community, and we're going to be doing a webinar to provide some additional information about that IRS guidance. But that, we acknowledge that not everybody has an HSA or FSA, but for those who do, the fact that they can use this benefit for a medical necessity is really great. So what are we doing next? We're actually working with Avalier right now to talk about market penetration into the payer community. How do we pay for the exercise prescription? That's going to be a focus for us this year. We're building out reference implementations for our implementation guide so that the end user, the qualified professional, or the community-based organization can link to the health system to follow through on the exercise physical activity referral. We're hoping to work with NCQA and others on quality and performance measure development, and obviously hoping for health systems to continue to integrate our implementation guide. We're working with some key health systems right now who are wanting to be early implementers. And we're staying in close touch with the White House as we follow up on last year's conference on hunger, nutrition, and health. As they get ready to announce second round of commitments, we are hoping to be part of that second round. But more importantly, seeing the interaction and the coordination across the regulatory agencies right now in this space, we want to take advantage of that and leverage that momentum. So that's where we are, and I'd be glad to answer any questions later on. Thank you.
Thank you, Dr. Witzel. And yes, as a reminder, the speakers will be around after for Q&A if you'd like to visit with them. So, Dr. Lucare.
Hello, everyone. I'm Namita Lokre, and I'm the Director of Corporate Strategy at Valencell. Today, I'm going to talk about cuffless, calibration-free blood pressure monitoring. But before I do that, I want to thank the AHA and the team here, Pat and Jeff, who have given us such a warm welcome to the Innovators Network. We are the newest members, one of the newest members. We joined 3 months ago, and we're happy to be a part of the AHA. So today, the theme of the talk is going to be why we're doing cuffless calibration, how we're doing it, and our solution, essentially. So, let's look at why we need a cuffless calibration-free solution. There are many barriers to managing hypertension at home, and the top barrier that we see is adherence. That could be adherence to medication, adherence to monitoring, and this is why most people cannot get BP under control. There's this question of accuracy of home monitoring devices, lack of solution that works for all. There are different special populations that cannot use a cuff-based solution, and so I think that is another cause. Challenges with cuffs, it's not a one-size-fit-all. You have to have multiple sizes, and most people at home do not understand what size to use. We also have lack of actionable data. You have so much data coming in for these physicians, so there's not a best way to understand what this data is or what action the user should take. And then there's also lack of education on how to get the best reading. Like, not many people know that they have to sit down for 5 minutes, put your hand above the heart and take a measurement. So there are many barriers to managing hypertension at home. There's the other question of home monitoring and the accuracy at a global scale. So we looked at two studies that were recently published. One was in 2020 and the other one was in 2023. And this first study, they tested 331 devices, and this was done in the UK. And out of the 331, 24% of all the devices that they tested failed the test. And 40% of those testable monitors were not validated for accuracy, and the fail rate was higher among them. Cuffs were also more likely to fail sooner than the blood pressure monitors. And lastly, the causes of these failures were attributed to overestimation of BP. The other study was more at a global scale, and the researchers studied the devices that were sold on Amazon in 10 countries, including the US. 79% of the upper arm cuff and 83 of those wrist cuffs were not validated for accuracy. Most of these non-validated arm cuffs were sold in India and Australia, and then most of the non-validated wrist cuff devices were sold in the US and Mexico. And so this is a huge challenge, not only at a global scale, but also in the US. And finally, we all know this. I'm just going to go quickly over it. There are cuff issues. Improper sizes is the largest source of error. Placement and calibration of these cuffs is an issue. Measuring of BP in obese population, stroke patients, and pediatrics and pregnancy, it's also an issue. And lastly, people with neurological disorders cannot take their own BP, so they need somebody else to do that for them. So what are we doing to solve these issues? So Valence Cell's mission is to empower people to live longer and healthier lives. And our device is a cuffless calibration-free solution. You can see the size of it. It goes on your fingertip. It gives you a reading with less than a minute. It is a PPG-based solution that you can set reminders as per your doctor's instructions to take 2 measurements per day. You can download the data, share it with your caregiver or your physician, and you can also add notes. So the device comes with a companion app, as you can see on the screen, and it can also give you trends over time. So how are we doing this? So the device has been trained on 20,000 plus data sets, which are collected by the ISO standard, which is essentially you take a first initial reading to get a baseline, and then it's followed by a sequence of readings sandwiched between a dual-headed stethoscope measurement with nurses. And so that's how we take our data. And once we take that data, we extract features from the PPG. We also take metadata features, and then we have a deep learning model that will estimate our BP. So under the hood, essentially what I said, you have this PPG waveform that we're getting from our device. You have all these fiducials on the PPG waveform. We extract these features. In addition to the metadata features, we feed it to the model, and you get a systolic and diastolic output. There are challenges with PPG data. Traditionally, if you've seen your activity monitors or your other heart rate monitors face these issues, such as motion artifacts, diverse skin types, and signal crossover. And our solution is dealing with some of these in the following ways. For motion artifacts, we're collecting BP at rest, and we have a state-of-the-art motion detection algorithm which addresses some of these motion artifacts. We have tested our device on diverse skin types. So I'll show you the results in the next slide, but we've tested this device and we have not seen no statistically significant results from all these Fitzpatricks. And then the last problem of signal crossover, we have these robust features that are shielding us from this effect. So we tested our technology over the 6 Fitzpatrick scales as seen. We did a study of n equals to 124 on these different Fitzpatrick scales. And we evaluated the PPG quality and also some of the metrics that we use that are proprietary to our algorithm. And here are the results. So over the quality and the forms that we use, we saw no statistically significant difference. Even with the normalized relative systolic and diastolic errors you see over all the 6 categories, you're not seeing that statistically significant difference. Finally, I would like to conclude this presentation by saying that the next steps for us are we're starting our clinical validation study in January, and we will submit by mid-May. And so if you are any one of these partners that are out there and want to work with us, please reach out. Thank you.
Thank you, Dr. Lokari. And so our next speaker, Dr. Seixas, please. I think I'll raise this a little higher.
All right, good afternoon, everyone. So my presentation is going to be a little bit different, where we're not going to necessarily have any data per se, but I come to you as a prophet or a clairvoyant person, because I think in many ways a lot of folks wanted to hear, what's next. And so just wanted to kind of share that, with you all today. My name is Azizi Seixas. I serve as interim chair for the Department of Informatics and Health Data Science at the University of Miami. We created a framework called Precision and Personalized Population Health, which is a translational framework that takes us from discovery all the way to treatments and solutions that has several different components, which includes awareness, avoidance, access assessment, acceptance, and adherence. So last year when I gave a similar talk, I was at the Media and Innovation Lab, and I spoke to you all about what we were doing. And I won't bore you with that, but we're doing it across 5 core vertical areas, from education to care to research to venture and service and outreach. And thanks to the AHA, I guess some word got out that I probably did a decent job, that I was promoted to interim chair. So my hope is that after today's conversation that we'll remove the interim status, or we'll elevate it, right? Dr. Paz says yes, right? Good. It's good to have friends here. So the Department of Informatics and Health Data Science is no different. We're still verticalized across 5 areas. And I'll just kind of share with you some of the areas that we have really focused on as areas that you should take note. And this is essentially our brand identity. So my colleagues my colleagues and I who are here really did a very deep landscape analysis and a SWOT analysis to see where are areas that you need to focus on. Excuse me. And this includes education. So here's what we do in terms of education. We rolled out several different innovation programs, teaching medical students and PhD students on innovation, because we believe the next generation of clinicians and the scientists must have innovation as a core pillar. After all, you are all here, but how many of you actually got solid formal training in innovation? I would say very few of you. We believe the next generation of clinicians and scientists must have this core element, because they are going to be the next founders, chief medical officers, scientific officers, and technology officers. And when we look at research, our focus is looking at rhizomatic data as well as real-world data, and you'll hear a little bit more. Digital biomarkers, decentralized trials. our clinical vertical focus on remote health monitoring, decentralizing care, and digital therapeutics. Our venture vertical, we're set up very differently where we want to work with companies. So this is really a pitch to you all that if you want to work with an academic health center, start with the University of Miami, because we've created an atmosphere where we have made it frictionless to work with academic health centers. And then our service outreach policy and ethics really focuses on how is it that we can fulfill our most sacrosanct virtue and role as being credible messengers in the community by the creation of smart cities, working with the city of Miami, creating digital health literacy program, solving digital divide, and creating social entrepreneurship programs. And you may ask, why is it that an academic medical center is going to be doing this? And this is how we're revolutionizing it, because what will happen is that if we as academic medical centers don't take on these challenges, then we're going to get disrupted from the outside in, and therefore we might be rendered obsolete. So let me just share in terms of how we're doing this in discovery. So I oftentimes say what we typically do in the discovery space is that we call ourselves data hunters and gatherers, and we try to establish infrastructure and security. Now, last year, everyone was in a big craze over big data, and I don't need to tell you what big data is. Last year, I spoke about data as being rhizomatic. And next year, as I said, my role is to be a bit prescient, a bit clairvoyant, is that I believe next year is going to be around real-world data. In other words, I believe that we're going to be focused more on diverse big data in context. So it's no longer just looking at these closed loop types of data from just singular homogeneous sources, but we're going to be faced with the challenges of more heterogeneous real world data that comes from multiple different sources, from different channels. And how is it that we're going to be able to harness, harmonize all those data for clinical and for research purposes? Well, we have already started to trailblaze this area. We've created a remote health monitoring solution that takes into consideration real-world data. We created the mailbox, where not only are we looking at biometric signals, but we're also looking at bioassays as well. And the reason why that is important is because we believe that in order for us to fulfill the value of precision medicine, or a framework that we create called precision and personalized population health, is that it would allow us to do digital and bio twins. Now, I want to share as well that awareness is going to be something that you have to look out for. Why? It's about the type of information, the way in which the information is provided, and some of the work that we're working on looks at different types of ways and modalities such as virtual reality as well as immersive technology solutions as well. We've used agents as well, using AI to do this type of work. Let's look in the space of avoidance and prevention. I think the previous speakers have spoken about how revolutionary technologies, particularly digital solutions, will be. It's already been announced that Apple is going to be investing significantly in having one of their watches assess glucose monitoring, and that's a critical area that we must look out for. But we also believe that immersive technologies are going to get a little bit more diverse, a little bit more nuanced, where it's not just about VR and extended reality, but we believe that it's going to be the ushering of haptic reality and haptic technologies as well. And we've already been doing this work where we've led, I think, a very public social impact program where we're trying to tackle and solve maternal mental health issues, particularly among diverse communities. And so this is a study that we're just about wrapping up, and my colleague Mary is leading that project. An amazing project, and you could definitely speak with her, not me. In terms of access, what would that look like? We believe that how technology will help us to increase access to care through a variety of different technologies and descriptions, from telemedicine to IoT devices, wearables, online support, educational apps. And I think some of my previous colleagues have already mentioned those, but I think that will get even more enhanced with the advent of generative AI. In terms of assessment, what's that going to look like? Well, we believe that biodiagnostics, just skipping over that, clinical testing is going to ramp up even more. We've done some work in this space using dry blood spot sampling, but we also believe volumetric absorptive microsampling. So what that means is that people can actually take a finger prick, absorb blood work, ship it off, and they get their results. That's going to make the healthcare system far more frictionless and more patient-centered. I believe I was in a panel yesterday, and I said we're not going to meet people at the point of care anymore. It's going to be a point of need. And I'll just wrap up quickly. We're doing some work in the space of cognitive aging. We're going to be using virtual reality to measure cognition. So no longer we're going to be wedded to traditional neuropsych assessments. And we believe that IoT solutions are going to be more and more frictionless as well. And in terms of acceptance, we believe that generative AI and adherence will help in that area. And what we're working on is trying to tackle social determinants of health issues. And then lastly, we believe that the future of technology and healthcare is going to really look in a very interesting way, whereby humans and technology are going to become more ambient and AI is going to become more human. Just figure that out. What it means is that the technologies that we're going to see is going to be more ambient and we are going to recede in the background. Why? Generative AI is just the precursor of what is to come. Many of us are computer scientists, and scientists say that interactive AI is on the dawn. So not only are we going to be able to get generative or general intelligence, but we're going to create autonomous bots, autonomous agents that are going to have recursive self-improvement. And so that really adds ethical issues that it's beyond this talk, and I'm more than happy to talk about that. So thank you very much for your time.
Thank you, Dr. Sages. And so Dr. Shrai, our final presenter for today.
While those are coming up, I would like to thank the innovation team for putting on this this wonderful session, as well as I'd like to thank the Noble Mind team, who I am collaborating with right now in some of the things that we're talking about. They asked me to take their product as kind of a jumping off place about where we're headed. So again, this is a future. My background is deploying and implementing, sustaining large systems within the DoD, and so I have an idea about how we actually get these things into production. So last Wednesday, I spent 12 hours in the cath lab. I did about 4 hours worth of procedures. I talked to patients and families for about 1 hour. And then 7 hours I spent on 3 different medical information systems, reading notes, typing notes, putting in orders, answering messages. That's 42% of my time that I spend taking care of patients. The other I spend taking care of the EMR. And so, you know, the goal is to move that needle just a little bit. Hopefully I can show you how. The Noble Mind team on Saturday have showed a little bit about what they're doing. We currently, right now, have the ability with dedicated medical large language models to summarize and analyze text. We can provide it back in a very readable form. We can also give diagnoses that are not yet in the medical record but are suggested by the text. We can then assess risk and add that to these summaries. And then we can suggest treatments. We're still working through this, but the early work with this is really very promising. A good example here is you can crawl an entire hospital, all the people admitted, and come up with the one patient who needs to have a TEE, patient number 523 in the lower right. The technology here is absolutely wonderful, and it's exponentially increasing. As somebody who's worked in informatics now for 15 years, I have absolutely no qualms about the technology. Although the things that I think about when I have a very clear technology that's proven and is going to improve even more, I try to figure out about how we get to implement these things in very large enterprise systems. And so that's where things get kind of cloudy. There are an immense number of barriers out there to doing this, and I've worked in the development space, I've worked in the acquisition space, I've worked implementation side, and I've done sustainment. And what I can tell you, technology is never the problem, never the problem. The barriers of security, things like sustainment costs, things such as regulations, just as we had come down from the White House recently. These are the types of things that, that break these projects and keep them from happening. So today I'd like to give you some sort of a roadmap about how we go from where we are right now, starting with some simple examples that maybe even are untethered to begin with, and then moving on to things that are a little bit more complicated. So as a medical student, I wrote 30 history and physicals during my internal medicine rotation, with a fountain pen actually just like that, and then went over that with my preceptors for hours. By the time I got to residency, I was writing over 200 notes a month. And since then, I've written over 60,000 notes. One of my primary jobs right now is to write notes in the medical record. It's a significant portion of my time. But not for long. Both of my adult children, they start with ChatGPT for their job, and then they move forward. My daughter's in digital marketing. All of her campaigns, she starts with ChatGPT, and then she edits. My son's in computer programming, likewise, can generate code, and then make things a little bit better with the human interaction. We're working right now with, to figure out how that looks in the healthcare space, but what I can tell you is it's going to revolutionize medical education. How you interact with these tools is going to be what's important, not creating all the content. I'm working right now with Noble Mind, and we're working initially with our clinical informatics fellows, but then expanding that out to some of our general sort of medical trainees. Next, and maybe slightly more complicated, let's say you run a healthcare system and you have to evaluate 143,898 disability claims each year. You have 600 FTEs assigned, and you spent $1.8 billion last year doing this, mostly just reviewing medical records. Unfortunately, you only completed 55% of your evaluations last year. And of course, I'm describing the VA disability system, a system that I went through as a retiree. It took me 9 months as a relatively healthy person. The technology is there. We have a grant in right now to go through and pull forward all of the VA-specific diagnoses and take away the 1 to 7 hours spent reviewing medical records for each disability claim. Next, let's turn to the patients. So Kaiser Permanente, where I do my clinical work, has 92% of their patients accessing their medical records digitally. Their patients send 44 million messages to their providers, and they also access the nurse triage line over 4 million times a year. There are certainly third-party vendors out there right now where they have AI chatbots that interact with patients, but I think the big step forward and the things that we're working on are how do we integrate with either tethered patient portals like the VA, or how do we integrate with the EHR vendors, because then you can use the existing APIs that they're already calling on to pull forward patient information and then make these conversations much more interactive and productive. Again, I think this is a wonderful place. We have a grant in place right now to implement the Army. The Army has a triage system for sick call. The algorithms, they're all published, and we're trying to implement that right now with a chatbot, and then extend that after the first grant to pulling back into the EMR and pull that data forward, and go from sick call in a tent somewhere to sick call on your phone, not even having to come in and see the providers. 73% of all enterprise health data is held in data warehouses. Of that data, 80% of it is unstructured text, meaning that it's essentially worthless. So, our goal is to look and pull forward that 80% of the data and use that to be able to do population health, diagnosis discovery, et cetera, et cetera. Basically getting the right people into my clinic to see me. And I'm going to describe a second problem that you might think is unrelated. So I'd mentioned medics. There's 39,302 medics in the U.S. Army. Now they work on laptops, low comms, no comms environments. They're frequently operating in numerous different languages across the world. They're doing relatively advanced medical care as well as trauma care, and they need assistance with those tasks. Again, looking at some of these chatbots that we're talking about on that side. But what I would say is that these are the same problem. So crawling the data center is literally the same problem that the medics have. Meaning, and the issue is this: you have to have a model that's task-focused, that can spare resources when it's running over billions of records or when it's running on an edge computing device. So we're looking at task-specific models because nobody can afford to crawl their data center every night for 500 million different problems. And so these are very interesting areas that we're going to, and obviously, you know, EHR integration, rainbows and unicorns, trying to get my 1,100 hours a year that I spend in the medical record back. I do think that near-term search is very doable with the vendors. I think the diagnosis discovery is very doable. I think it's going to take a little longer to get note suggestion, kind of first draft note suggestion, but I think that's not far off. I think orders are going to be a big long pole in the tent because the legal issues, the issues with integration, the issues with sustainment are just daunting. This is an area where we're starting to think about it. That's one area I don't have a grant in for, but I'm starting to think about how we nip at the edges there. So to finish, this is a patient that I saw in the last couple months. She is an aged Hiroshima survivor, Japanese. She has been very worried lately because she's been having some falls, and she's very concerned about her ability to care for herself and whether she's going to be able to continue living alone. She was recently diagnosed with chronic lymphocytic leukemia, and she comes to see me for an arrhythmia. Now, my EMR would tell me that I have a 93-year-old with an ICD-10 code of atrial fibrillation, that there's a SNOMED medication that was given called apixaban, and that I had an office visit of a certain level. What we currently have fails to understand the human person. And you know, I'm hopeful that as we extend these things out, we can bring in the richness of human beings and what we can offer as healers. So where we're going, and where I hope we're going anyway with language models, is that we can much better express the human experience, and then secondly, that we can go from 42% of the time taking care of patients to 60, 70, 80% or more. Thanks.
Thank you, Dr. Shah. I appreciate that. And to all of our presenters, let's give them a warm round of applause for effort. Thank you. And lastly, I'd like to point out that among our presenters, we had 4 of them who are members of our Innovators Network, and that's an opportunity for us to work more closely with them. So Found Health being one of those as our members. Clearly Health is up, Uda, there you are. Valence Cell is one of those groups, and Hello Heart. So we appreciate that. And then since we're talking about what's new in the Innovators Network, we do have a few new members that would like to bring up and introduce. Hassan, are you waiting for your call, please? Kristen? And Mr. Carter? So these are our recent new members here in the organization, and Hassan, with Toku Eyes, and if you've had a chance to see their pod over there and the interesting they're doing around eye image. So we'd like to welcome Hassan as founder, president, and CEO at Toku, who's one of the newest members of our Innovators Network. And as founder of Toku, Hassan's journey in the world of healthcare tech is deeply rooted in a personal experience close to his heart. Hassan's father lost his vision when he was only 4 years old due to poverty, lack of access to public and basic health screening. And this experience lit a fire with him, driving a strong desire to create solutions that empower individuals to take control of their health and avoid preventable diseases. So fast forward to today, and Hassan, along with his Toku Inc. business, is at the forefront of healthcare innovation. Their groundbreaking AI technology, Claire, boasts the coveted FDA breakthrough device designation during a routine eye exam. So Claire offers real-time assessments of the risk for atherosclerotic cardiovascular disease, making early detection more accessible and efficient. So Hassan's dedication, fueled by his personal experience, is a driving force behind Toku's mission to redefine healthcare and enhance the quality of life for people worldwide. They're not just developing tech, they're transforming lives one eye exam at a time. So thank you, appreciate being part of this. And so with our next membership with the I3 Medical Group, so we'd like to welcome Raymond Curtis to our stage here with I3 Medical as one of our newest members of the network. So with I3 Medical, more than 350,000 people suffer OHCA every year in the United States, with a stagnant survival rate of 10%. Combine that with the ever-growing number of respiratory arrests due to opioid overdose, and that number is much larger than over 350,000. So I3 Medical is on a journey to provide a device that combines an AED with a software-controlled ventilatory support device that will enable lay rescuers to administer effective cardiopulmonary support. So bystander cardiopulmonary life support commonly includes the chest compressions and defibrillation. Respiratory support is often overlooked due to the training requirements, the complexity, or the inaccessibility of currently marketed devices out there. So I3 Medical intends to change that paradigm while also paralleling the AHA's mission to train lay people in high-quality CPR. So I3 Medical aims to put the A back in the ABCs and strive to become a relentless force for a world of longer, healthier lives. So thank you very much. Appreciate that, Curtis. And our third member joining the network recently is Imago Rehab, Kristen. And so we'd like to welcome Dr. Nichols, who is co-founder and chief clinical officer at Imago Health and Rehab, as one of the newest members of our network. Imago Rehab is a revolutionary tele-rehabilitation program born out of Harvard University that is designed to provide comprehensive and specialized therapy for stroke survivors experiencing lasting physical effects. With a focus on improving limb function, increasing independence, and promoting mobility, Imago Rehab currently offers a range of benefits that can greatly enhance the recovery journey. They plan to expand their offering to speech therapy, vascular, and cardiac rehab in 2024. Imago's physical and occupational health therapy is delivered through a 100% virtual setting, allowing stroke survivors to access therapy sessions from the comfort and convenience of their own homes. The program is led by experienced therapists with a specific focus on neurological rehabilitation, ensuring specialized care and effective treatment. In addition, Imago utilizes cutting-edge medical devices, including patented robotic technology, to enhance therapy sessions and provide targeted exercises for optimal recovery. So we welcome Imago Rehab to the network, and thank you for coming up. And that concludes today's session. Thank you for your time, and if our presenters are available for questions, maybe you can meet over here on the side. Thank you again. Appreciate it. Thank you. Yes, sir. That's good.